So we have a small change in program, and for next session, instead of Dr. Changappa, we'll have the topic by Dr. Joe Thomas. And to chair the session, I invite Narayanan sir, consultant rheumatologist, Care Kochi, and Abdul Kadir sir, professor of medicine and consultant rheumatologist, Pushpagiri Medical College Hospital, Tiruvalla. So over to the chairs for the session. Thank you.
Hello. Good afternoon. We'll start the next session. So the speaker is Dr. Joe Thomas. As all of you know, all those who are in the IRA, we know that weekly interesting clinics by Joe. So we look forward to that, mostly based on radiology. So there's no better person here to speak about MRI. The topic is the role of, I think, the MRI in axial XPA. Without Joe is consultant rheumatologist in Ashta Medicity Cochin, and over to you.
Thank you, sir. Good evening, everybody. I thank the organizing team for inviting me. I remember the late Kakala Subbarao sir, I think JC sir will remember, who inspired me to, my passion in musculoskeletal radiology. So there are two disclaimers. One, I have not spoken in a forum like this for over 6 to 7 years, and most of the list of the speakers I saw were very eminent. So if I am not up to their mark, please do forgive me, because I am out of touch for years together. So when this topic came up, interpretation of MRI, SI joint, what not to miss, I think this is a topic which I can talk the entire afternoon session. It was such a big topic. So I didn't know what to say, because I've been given 15 minutes. So I rang up my guru, Sri Dr. Padmanabha Sharanay Swamiji. And the Swamiji's wisdom in rheumatology is unparalleled. I asked Sharanayji what to do. This is a topic. And he said, you give 10 clinical points. That's all. Don't talk too much. Just give what is useful for day-to-day practice. And as you know, the Swamiji is not here today. He's giving wisdom to about 500 people now, and probably addressing this gathering tomorrow. So thanks to Swamiji, I'll be talking about these 10 points. So irrespective, even though this talk is about MRI, always remember the first investigation of choice in your day-to-day practice still has to be a simple plain radiograph. The recommendation from the SAS or the Spartan is to do either a AP view of pelvis or what we call as Ferguson view. But in clinical practice, this is not what we follow. We do an MRI, the X-ray of the spine, AP, and also a lateral. Why this is important is, I think, as you can see, this is a lady, is a staff of ours who presented with right SI joint pain. So problem clinically it looks like a right sacroiliitis. But if you look at it, the person has scoliosis. This is a transitional vertebra. So this is what we known as SI joint dysfunction. So the pain is related to SI joint is because of the transitional vertebra and scoliosis. So we also do a lateral view, because many of the time the pain may be because of a spondylolisthesis, spondylolysis. So this is what is very important. So this lady who was around 30 years had features of inflammatory backache, was diagnosed to have SI joint dysfunction just based on X-rays. So here we don't require another investigation, because this is good enough. Even if you do an MRI, we will see the stress changes, other changes which can make us more confused. So once you see this, I told her we will give her physiotherapy exercise and come back to me. So the first point to take home is X-ray is still the first choice of investigations. Then most important thing, as I spoke earlier, we need to know what the protocols should be taken. Because now the SAS has released a new guidelines last year, Especially this is related to SI joint. But generally what we follow in our practice is we do an SI joint protocol along with the screening whole spine protocol. Why we do these two is for two reasons. One, many times you can have, less than 5%, you can have isolated spinal involvement. Second, many times we are confused whether SI joint pathology, is it a real spondyloarthritis pathology or are we dealing with something else? So if you see a SI joint pathology with spine changes, that will help us to label the diagnosis much more confidently. So the acquisition protocol is one. We need 4 sequences. One is a stir sequence or a fluid sensitive sequence. They have different protocol. What we do is a stir sequence. This sequence is where we look for the bone marrow edema. Second is a T1 weighted images. This is for the structural changes where you look at the fatty metaplasia and all these things. This is T1 weighted image. The third one is something called erosion specific sequence. These are different sequences, vibe sequence, based on the machine. Like you have Philips have different machines. All these have different categories. So basically, if you talk to your radiologist, find out what the machine and what the protocol they set it. And the fourth, the present ASAS guidelines also. So the first 3 images what you see here are called semi-axial. This is very important because most of the time what they do in a routine practice is a coronal image, which is again of no use. So acquisition in a semi-coronal, that too in a very thin slice. They do it about 3 millimeter or 2 millimeter cuts without gap. That is very important. And they do a semi-axial also is very important, which is a stir image. This is important to look at the location of the lesion. For example, if you have a spine, if you have a SI joint lesion, you feel there is an edema, you have to tell us, is it an anterior part of the joint, the middle part of the joint, etc., which I'll come across now. So these are the 4 sequences, the stir, the T1, and we have a specific sequence to look for erosion, and a T2, and one more sequence of stir image, that is a semi-axial. The most important thing is whenever we go, everybody comes with a film. The first thing is to start, if you want to really interpret films, is to throw that films in your waste bin, because none of this with the films, even the best of the radiologists won't be able to interpret. We can just, for the sake of the patient, this is what we also used to do, look at the films like this, look at the report like this, yes, spondyloarthritis, done. So patient is happy, everybody is happy. But as of now, we are not doing justice, because based on a simple film, it is not possible to even, you can say to some extent when you have a florid changes, but when you are in dilemma, interpretation based on films is absolutely of no use. I still don't know why these people, I think it's for the happiness of the public which we give films, that's all. Because you just need a CD. Once you have CD, this is a free software available, everybody can download, it's called Radiant, or you can go to the CARE website of the ASAS people. This is also free software. You can just download it, use a CD-ROM and use it. So a CD is just hardly 100 rupees, even the cost for the acquisition, because generally the people charges about 500 rupees for the films, which is of waste. You just need a CD, which is hardly 10 rupees. And CD, this is freely available in all platforms. You can just download in your laptop and use it. So if you have any doubt, and there are more similar software. I have about 4 similar software in my laptop, which I use it differently based on, that day, whatever it is. But Radiant is something which everybody commonly use. Or this one is, this CARE DICOM is from the group in Canada, which is also freely available and freely useful. Then the most important, so I have gone from now the MRI protocol to acquire. Then you are looking at the DICOM images. Once you have the DICOM, you need to know where to look at it. That is the most important thing. So this is how the DICOM should be looked. We should have a simultaneous stir images and T1 image side by side, and then scroll across like this. Now you understood why I asked to put it in dark mode, because you will not be able to see these images well. That's why I told switch off light, because this is more important to see. So this, what you see on the left side is the stir, other one is T1. So how to differentiate? The T1 will the fat will look bright, whereas stir, the fluid will look bright. That is a simple thing. So this is important, because so this is the anterior joint. So as you come, this is again the anterior part, and this is called the transitional side. What do you mean by transitional side? As you all know, we have 2 compartments, the synovial compartment of the joint and the cartilaginous compartment. So as you see in these images, This is the cartilaginous component. This is called a transitional sites. So from this slide, generally for these guidelines where they do the scoring system, the quadrants, etc., which I am not going into, they look at the transitional slide first and then they go up. So this is where we should look for SI joint changes. This is where we should look for the activity, etc., which I will be talking about. So this is the anterior mode joint, and if you look at these images, you can see bone marrow edema. You can again see if you look at the criteria, you can call this patient as spondyloarthritis. But I labeled this as patient as an a SI joint. I asked them for physiotherapy because if you look at this bone marrow edema, it's just a very focal bone marrow edema. Even though it is there in the multiple slices, this is especially seen in the anterior slide. So that again indicates this is a stress change. This is stress in the SI joint causing bone marrow edema. So this patient didn't have spondyloarthritis. So even though there is bone marrow edema, that is very important because that was the anterior most part of the joint where you, especially in the runners, etc., you see these changes. And as you see, you go back, once you see the joint looks widened, these are the cartilaginous part. Generally, we don't look much except for the enthesitis changes. But generally, these are the areas which we should not consider much in assessing spondyloarthritis. So these are all, so simultaneously look for it. So you compare both T1 and STIR together, and then that gives you a better definition of what is happening. So this patient, if you look at it, is having some bone marrow edema changes, but these are all more focal changes. I'm not going to depth, you should ideally have more depth and etc. for the bone marrow edema to say how significant it is. So so you have seen how many slides are there. Whenever you are going to get a DICOM image, hardly 50% of this will be provided. So if you look at these my images, there are about 50-60 images which they have it. So this is very important when you are looking for DICOM. That's why the importance of DICOM images. And this is the most important thing of the take-home point. Whenever radiologists see bone marrow edema, they see as if they are seeing Sunny Leon. They get very excited. They label it as spondyloarthritis. They forget anything else. That's the most important. Most of the radiologists think as soon as they see this, they don't look at anything else. They think this is, they get excited, this is spondyloarthritis. But most of you know, there are two sets of it. There is the activity, there is the structural changes. Out of the activity, there are 6 activity changes. Out of this, 1 is bone marrow edema. And it is one of the more non-specific things in spondyloarthritis. Everybody forgets about capsulitis, joint space enhancement, inflammation, enthesitis, and then you have the structural changes. See, the most important thing is when you have structural changes, that gives you a better idea of how good this diagnosis is. If you just see a bone marrow edema, just the previous case I showed had only bone marrow edema. So I am very confident to say, and also I just screened the entire spine to say that that patient doesn't have spondyloarthritis. I have no confusion. Even though the radiologists are reported as spondyloarthritis, my diagnosis was very simple because patient had a very focal here and here patchy bone marrow edema because everybody thinks about the classification criteria. They don't forget that these are not diagnostic criteria. So this is a set. You have the activity against, you have lot of structural changes. So this is a case of osteitis condensae ileae. This is one of the mimickers which we all see. So look at this. On the left side, you see the STIR images. This is the, the T1 images. Anybody would like to say anything more? So see, if you look at this, you can see bone marrow edema here. See the bone marrow edema? It is very subtle, but bone marrow edema is definitely seen. You see that there is a lot of sclerosis, especially you look at this images, sclerosis. And in this thing, you can see even fatty metaplasia. So please understand, even you have structural lesion, but again, if you look at this, the sclerosis is the predominant lesion here. That is what makes it important to say that this is OCI. And not put the X-ray of this. The X-ray is very classical. Once you see the X-ray, this is not important. So all these parameters are in there. There is some amount of edema here, not very clear. There is definitely a fatty metaplasia here. There is sclerosis. Still, we know this is osteitis condensae ileae. So this is, again, if you look at here, you can see bone marrow edema here, some amount of bone marrow edema here. So it's a combination of things. In radiology, it is never one thing. It is, you have to, that is why I said, don't get excited by bone marrow edema. leave the bone marrow edema is the last thing, because that is very easy to identify. Look at the other things which is there or not. That is what is important. So again, if you look at it, there will be changes, because there are a lot of other things. SI joint is not a very simple joint. It's one of the most complicated joints. So you see a lot of changes which you need to do everything into toto. This is a rule which has been proposed by the ASAS. The rule they say, it's easy to remember, 3, 4, 5. What do you mean by 3, 4, 5? One, you look at 3 SI joint quadrants with erosion. So what is this sequence? This is the wipe sequence. You can see the erosions better here. Look at the erosions well. So this sequence is very specific for erosions. So if you have 3 quadrants with erosions, that gives you more weighted. Nothing is perfect, but that gives you more. When you see erosions, it's more specific for spondyloarthritis. So this is a sequence. So if you have 3 quadrants with lot of erosions, like you can definitely make out erosions here. I hope so. Maybe if you switch off my camera, that would be better, I suppose. So this is, again, you look at this. Look at the erosions you see. You see the break in cortex. You can see the erosion so nicely in these images. So first is 3, stand for 3 erosions. Then comes the next part. So see, look at the time it takes me to scroll down. So many images are there. So many cuts are taken which we miss in the films. Then comes the, as we all very fascinated about, the bone marrow edema. So as you see, this is the anterior-most area, and then you see, look at the bone marrow edema. It is so florid. Unlike the previous images, you can see the bone marrow edema is so florid. We know this is spondyloarthritis. There is no doubt about it. It is bilateral here, and it is the depth is more than, I think, I forgot the exact say. They say 2 millimeter or 5 millimeter depth. They have a specific size which makes you give you more this thing. So look at this, you know this is spondyloarthritis. When you see a bone marrow edema, please remember when you are dealing with like a spondyloarthritis, this is what you expect to see in most of the case. That is why there you are very sure that this is spondyloarthritis. But along with that, you need to make sure that you look at the other parameters of these conditions. Then comes the fat. So if they say if you have more than 5 fatty lesions, so that is what it stands for, 3, 4, 5. 3 erosions in that you have to look at the quadrants, which is usually for this one. Then the bone marrow edema and the fatty lesions. So fatty lesions, you look at this, again you can see the erosions here. And you can, this is fatty metaplasia. You can see the fatty meta is a well-defined. The fat in fatty metaplasia means it's a very well-defined lesion along to the borders of spondylo, in the SI joint. So if you have more than 5 lesions, this is important for it. So this is 3, 4, 5 stand for erosion, bone marrow edema and fatty lesion. So this gives you a better weightage when you are reporting spondyloarthritis. The most other important thing is to recognize when it is not a mimic. Mimics is something which, very common, and very what is to say when it's not a mimic. So this is one case I recently got from Dr. Bhavin Jankaria. Because I took his slide, I'll tell you why. I asked him for a specific images which is there in this sequence. So this is, I think Sir said, this is this is a case of tuberculosis. Why do you say it's a tuberculosis? This is unilateral involvement. The most key important is there is lot of soft tissue involvement. Once you see soft tissue, there is no question of being it's a spondyloarthritis. Forget about it. Once you see soft tissue, it is infection, infection and infection. So this is, I think, 2 images Sir has taken, I think one in August and one is in October. So this is the, I think, before starting ATT, and then I think they have done a sequential MRI after 3 months, and you see the soft tissue component coming down. And then you see the erosions. So this is a sequence where they have taken erosions. So they in Bombay, they have a new, I think we will have it in next 3 months to 4 months in Asta. This is a new sequence which I will be talking. It's called zero-TE imaging or a synthetic CT imaging, where the MRI looks like CT. So this is, if you look at this, these are not CT images. These are MRI images where the MRI looks like CT. This is called zero-TE imaging. This will help us to identify, as you see, there is a lot of structural changes in this side which is much more well defined with CT. So instead of doing a, many times we do a associated CT, we can avoid it, go for this protocol called zero-T imaging or synthetic imaging. So that's why I specifically requested for an image from him for the zero-T imaging, because I didn't have one image of that. And then think of the differentials. Whenever you see, it is not about one diagnosis. Anything is possible. It's just a joint. Please remember, it's just a joint. So anything is quite possible. If you look at this, it could be stress-related changes, stress fractures, osteoarthritis, dish. This is a list I got from one of the atlas for spondyloarthritis. These are the entire list. Malignancies, paraplegia, anything is possible. And why I am saying anything is possible is this is one case where the patient came with left SI joint pain, and finally it turned out to be an osteochondroma of the SI joint. So when I was going through the case series to select for this, you could see malignancies, you could have infections, you name it, anything. You can have, crystal arthropathy, you can have gout, anything is possible. It's just a joint. So just please be aware that SI joint involvement is not equal to spondyloarthritis. And this is something which people don't, especially the radiologist has to be aware. There are normal variants. What do you mean by normal variants? These are variants which are, congenital variants. Why it is important to know there are these variants? Because these variants can give rise to various, SI joint changes which can mimic spondyloarthritis, which can cause stress changes, erosions, etc. So very important, these things needs to be addressed before you commit to a diagnosis of spondyloarthritis. And I think what is new and what is emerging. Out of this 2 points I am updating. One is the latest MRI technique which I spoke about briefly, and other is the ASAS new classification guidelines which was just discussed in the concluding ACR. So this is what I told earlier. This is called a synthetic CT or a zero-T imaging. This is taken in a big way in the MSK radiology session. These images you look, these are not CT images, these are MRI images. This is a semi-coronal image. So this is probably the machine we are getting in Aster now. So I got an image from them after that. So this is a semi-coronal, semi-axial images of the SI joints. So this will make our life much better in saying, is there erosion, is there structural changes, instead of doing a CT correlation many times. So this is the latest ASAS guidelines which is has to be published, come out in this one. Out of that, they are given 8 points to MRI indicative of axial spondyloarthritis. But the most important thing is, they have not so far mentioned what is MRI indicative of axial spondyloarthritis, because they are waiting for the publication. I send an email to the author saying that what do you mean by MRI indicative of spondyloarthritis? Means what erosions, what bone marrow edema parameters, what are the 6 structural and 6 activity lesions which they have included in these 8 points. I think they will be coming out in 1 year's publication, and then we will know. So this is the latest ASAS revised. Again, it's a classification criteria. It is not a diagnostic criteria. So my take-home point is very, very, very simple. I think most of you know about the Mahabharata. I think, this is the Mahabharata story. I think the Arjuna, this is Dronacharya, asking Arjuna, what do you see, Arjun? So he says, I see the eye of the bird. That's the only thing I see. I don't see anything else. But this is 2025. The Arjuna again, Dronacharya again asks Arjuna, sorry, I think this is, so again ask Arjuna, what do you see? So here, he again says this is the eye. Then Dronacharya tells him very politely, you idiot, you see there is a big beehive behind it. If you by chance miss that bird and hit that beehive, you are dead meat. You see the full picture. Don't forget about the eye of the bird. You see the full picture. That is my simple take-home message, my friends. Radiology is not about one image. It's about the complete set of things which we need to look at it. The clinical picture, the complete sequence of events. And don't be like Arjuna. You have to change, or you're going to be bitten by the bees. Thank you.
Thank you, Joe, for an excellent talk. Got one question. So, actually, we started this MRI for diagnosis of spondyloarthropathy. We used to say conventional X-rays take years. Now, with this, how early should we image? So, can we overdiagnosis? Will you overdiagnose spondyloarthropathy by doing an early, only the edema may be there in the early stages, I suppose.
So two things. The overdiagnosis is because of lack of knowledge from the radiology part. So if you clinically suspect you don't have a radiographic features, you have to do an MRI. That is why the latest criteria has given 8 points. The total points is 11. Out of that, 8 points go to MRI indicator of spondyloarthritis. So if you suspect spondyloarthritis, very likely, especially in the early, you are not going to see anything X-ray. You ask for MRI. So it's gone are the days when I used to do just an X-ray and wait, If you, I think we should do, whenever there is possible. This is my usual take is that whenever required, when you are not sure, always go for additional imaging. The X-ray is never the final imaging. You should go ask for either ultrasound or MRI because many times we miss these things in X-rays and this one. So the point is very simple. The diagnosis, if you want to make a diagnosis, MRI is must. Second, if you're going to misdiagnose, that is because the radiologist may be misinterpreting an bone marrow edema. That's all. Because it is like structural lesions can be seen in the earlier stage. It is like we were told that our thing is that structural take years to happen. It doesn't happen. Many times we see all these things simultaneously. That is what happens.
Sir, regarding the question that sir just asked, sometime back there was one research study in ARD that looked into HLA-B27 positive relatives of patients with seronegative spondyloarthropathy, and they found that if they are just HLA-B27 positive, not just with any clinical symptoms, and if they image, the incidence of sacroiliitis is higher. The thing is that spondyloarthropathy is one disease we know which has a very atypical, it's not kind of an additive arthritis like rheumatoid. It can be quiescent for many years together without any manifest. So this is a question that we may have to probably have a lot more data to appropriately this thing, because if we image HLA-B27 relatives and picking up without a symptom, whether we are going to treat, that's another point that is worth pondering.
That is why, sir, we need to look at the whole picture, as I said, because it is not the imaging you see. You need to see clinically what the patient has and then interpret it accordingly. That is why this makes it for us as a rheumatologist to know about SI joint interpretation in our day-to-day practice, which is very simple using a DICOM images. That's what I would say.
Very common in children to actually, wrongly diagnose sacroiliitis on MRI because normal marrow, the maturing marrow can be mistaken for edema, and at the same time, again, positioning of the patient can lead to false impression about inflammation and edema.
Absolutely very agree, madam. I think imaging in kids is a totally different ball game. Interpretation of SI joint is again totally a different ball game. It is very, you need to be really good in interpreting children SI joints. Otherwise, because the red marrow will look, bright, and then you will interpret it as, bone marrow edema, etc., and all these things. So, children are totally a different ball game.
Usually observe, especially female, they come with low back pain, and especially after labor. If they come, take an MRI, most of the time we see some bone marrow edema. So I think that sooner likely to be assessed due to parents. It's a very common.
Absolutely. So this is called postpartum edema, which is very common in this one. So the literature says that ideally all this should disappear by the end of 6 months to 1 year's time. And these people can come with pain and all these things. So I think this has to be managed symptomatically rather than again labeling as spondyloarthritis. Again, the changes what you see in postpartum are in the anterior joints. And other thing is structural changes are not seen, especially fatty metaplasia and certain things. So it is this, whatever you see in postpartum period is edema, and literature says it usually disappears by 6 months to 1 year. So re-imaging may help us to make a definite diagnosis.
Sir, one last question. Sir, I often get from my ortho colleagues, they do MRI for back pain. Finally, some edema comes up and the radiologists interpret it as sacroiliitis. Chronic sacroiliitis kindly correlate. Clinically, there's nothing to suggest a sacroiliitis, sir. Now, that bone marrow edema, how do you convince the patient, sir? I mean, do you repeat it later on, or you just tell them it's all right? Because then they go for a second, third opinion, and then just they keep on going. So, how's your approach to?
So two things. One, they have to make sure many times what they do is a coronal imaging. And coronal, you see this. So ideally, the first process, if you can do, is to see whether the imaging is taken properly. That is the semi-coronal, this one. And then you look at, most of the time, the reporting would say sacroiliitis. And this is because the edema is there. But if you are not clinically not fitting, if you feel that there are no other features to say spondyloarthritis, you are 100% you can ignore it. There is not, absolutely you can ignore it. You just have to say, I confidently say to the patient that this is not spondyloarthritis.
Do you repeat it, sir? Sorry.
Repetition, if you strongly suspect, you can repeat. But I think there is no recommendation to say repeat, because again, if you are looking at stress changes, that changes may be present earlier also. Or if you are looking at SI joint dysfunction, which is something which we all miss, because SI joint dysfunction is a separate entity. So as I said, there's a huge list of things which can happen. It could have been exercise and all these things. So just because you see few bone marrow edema, clinically, if there is no suspicion, don't repeat. If you have strong suspicion, maybe you can repeat it after 6 months, but there is no definite guidelines for that.
Is there allowed for a differential scan or some CT?
No, sir. No load. As of now, earlier we used to do bone scan, all these things, but I think MRI is a very, very sensitive image. So that's what Vishal has told. The sensitivity is a problem. So it is very important for us to identify what is there. Reality, is it really a spondyloarthritis or not? So that is what is important.
Okay, thank you, Joe, for a wonderful lecture. We'll move on to the next topic.
The next topic is by Dr. Hafiz Mohammed. He will be talking about the glucocorticoid-induced osteoporosis, what is beyond ACR guideline. Dr. Hafiz, please.
Thank you, sir. Good afternoon, everyone. It's actually very hard to follow a talk like that, but still I'll try. In the next 15 minutes, I'll talk about glucocorticoid-induced osteoporosis. We are all very familiar with the ACR 2022 guidelines for glucocorticoid-induced osteoporosis. It's very popular, not just among rheumatologists, but also anybody who deals with osteoporosis and who deals with steroids, including endocrinology, nephrology, respiratory. We'll quickly go through the ACR guidelines highlights, and then we'll finish off with a couple of cases. I don't have any disclosures. I'm going to start this talk with some well-known figures in osteoporosis. To be frank, if you listen to any talk in osteoporosis, you will see this as the first slide in most of them. It's still worth repeating these points because osteoporosis is important. Treating osteoporosis is important. It's no longer an optional thing to do or a nice thing to do. It's a must thing to do for our patients. With 1.4 billion population in India, estimated osteoporotic fracture rate is 1.5 to 3 million per year. That's a huge burden. There's something called imminent risk or fracture catastrophizing. If you have a fracture, there is a high chance that you may get a second or a third fracture in the next 1 to 2 years. And it's not just the fracture, it has an implication on mortality also. If you have a hip fracture, there's up to 1/3 chance that you may not survive the next year. And if you have a vertebral fracture, 8 to 15% mortality in 1 year. It's that serious. And even in patients who survive, 50% of them never regain the previous mobility. And all this is a massive economic burden. We all can imagine if one of our relatives or somebody gets admitted with a hip fracture, that easily few lakhs spent in the hospital, plus the other rehabilitation and other economic burden. The good thing is we now have a lot of interventions which can significantly reduce the incidence of osteoporotic fracture. With that introduction, I'll come to glucocorticoid-induced osteoporosis. It's the most common secondary cause of osteoporosis after idiopathic osteoporosis. Between 1 to 3% of adult populations are on chronic steroids. And if you're on chronic steroids, there's 30 to 50% chance that you've already had a fracture or you're osteoporotic. Patients on steroids are at 5-fold risk of having a vertebral fracture and 2-fold risk of having a hip fracture. Now, we all have many patients. Ideally, we want patients to be completely off steroids, but despite best of our efforts, we may not be able to get them rid of steroids completely. But when it comes to bone, there is no dose of steroids, but it's actually safe for bone. So in this study from Japan, this is actually an insurance database study, they've compared fracture incidence between patients having multiple doses of steroids. And if you look at the chart, you can see even at a dose between 1 to 2.5 milligram, the fracture incidence is higher than the reference group. And there's a dose-dependent effect also. The higher the dose of steroid, the higher the risk of having a fracture. The other thing that you can see in this graph is the fracture rate actually increases as early as within 3 to 6 months. The bone density decreases as early as within 4 weeks, and the fracture risk increases within 3 to 6 months. So if you plan to start a patient on steroid, the best thing that you can do for their bone is to plan osteoporosis treatment right at the beginning of the course of steroid. And the fracture risk in glucocorticoid-induced osteoporosis is not just related to the loss of bone mineralization, that's one factor. But for any given bone density, for an age, the risk of having a fracture is more if you have glucocorticoids than if you don't have that risk factor. Which means it's not just the bone density. Of course, glucocorticoids decrease the bone density, but it also affects the quality of bone in general. One good thing is fracture risk rapidly declines with discontinuation of the treatment. Any dose reduction, any attempt to taper prednisolone makes bone healthier. The risk does not revert to the baseline, but there's a significant reduction in the risk. Again, if you look at the chart from the same group, glucocorticoid continuation group and glucocorticoid discontinuation group, you can see the significant reduction in the fracture risk. It doesn't come back to the reference group, but it's still a significant reduction. So any attempt to taper, we must utilize that. These are some of the predictors of fracture risk with steroids, which we can see in various studies. There is nothing new here, it's all common sense. If you have low bone density, there's increased risk of fracture. Increased dose and duration or increased cumulative dose of steroid, there is increased risk of fracture. Female gender, age, increased falls, and use of some other drugs which can accelerate osteoporosis. All of them predicts fracture risk with steroids, but this is true with any cause for osteoporosis. Now, the treatment option that we have available now includes anti-resorptives and anabolic agent. Anti-resorptives includes bisphosphonates. Oral bisphosphonates are alendronate, risedronate, and ibandronate. And then you have IV bisphosphonate, zoledronate. Pamidronate is a bisphosphonate, but we don't use that much of pamidronate in osteoporosis. Then you have denosumab, and then you have raloxifene, which is the SERM. And for like last 7-8 years, we have many anabolic agents in the market, which includes romosozumab, which is a monoclonal antibody against sclerostin. Teriparatide, which is an analog of parathyroid hormone, and abaloparatide, which is an analog of parathyroid-related peptide. So anabolic agents and anti-resorptives. So with this background, we'll go into ACR 2022 guidelines. This is the 2022 guidelines. We are all familiar with this. So the guidelines is for any patient who is on glucocorticoid more than 2.5 milligram for a duration more than 3 months. That's the entry criteria. If you're on this, if you are starting a patient on steroid, or if the patient has been on some dose of steroid, or if you're planning to start them, so all of these patients has to go through this flowchart. The first step is clinical risk assessment. Look into all the factors that can contribute to osteoporosis, which includes dose and duration of glucocorticoid, cumulative dose, other risk factors, which includes alcohol, smoking, hypogonadism, low body weight, parental history of fracture is a significant risk factor, history of falls, thyroid disease, both hypothyroidism and hyperthyroidism, hyperparathyroidism, rheumatoid arthritis, diabetes, any chronic disease, any bowel disease. So look into the clinical risk factors, and ACR makes a distinction between adults less than 40 years and adults more than 40 years. In adults less than 40 years, you do a spinal imaging, which could be a vertebral fracture assessment or a conventional spinal X-ray. So do a spinal imaging and do a DEXA scan for adults less than 40 years. For adults more than 40 years, do a DEXA scan, do a spinal imaging, and do a FRAX. FRAX is not validated for patients who are less than 40, but for patients who are more than 40 and you're planning to start the patient on steroid, do a FRAX. Now, we are all well familiar with FRAX. FRAX, they have recently changed their website. The look is more professional now. But for people who have been using the previous version of FRAX, this looks very, like, they don't feel very familiar with this kind of an interface. But it's the new FRAX that we have. Basically, it's the same as old website. It's freely available. Make sure you put the country as, like, the country of the patient, that's India. And you have all these points, like, which you have to click. If the patient is on steroid, just click the steroid. If the patient has previous fracture, just click the previous fracture. If you have bone density available, put the T-score or the bone density there. If you don't have bone density available, you can still do the FRAX. You have to just leave that 12th point empty. There are a lot of criticisms around FRAX, not criticism, but shortcomings, because if a patient has a previous fracture, you can click yes. But if a patient has 2 or 3 previous fractures, you can still click yes, but there is no dose dependency. The same way with glucocorticoids. If a patient is on glucocorticoids, you can click yes, but it doesn't make a distinction between low dose, high dose, or very high dose of glucocorticoids. So the ACR recommends glucocorticoid correction, which basically means you do the FRAX, and if the patient is on a high dose, defined as more than 7.5 milligram, increase the major osteoporotic risk by 15% and hip fracture risk by 20%. Just to give you an example, if a patient is on prednisolone 10 milligram for 3 months, the FRAX is 18% and hip fracture risk is 2%. That would normally be classified as moderate risk. But if the patient is on steroid for long term, you do a correction. That is 18 plus 15% of 18 and 2 plus 20% of 2, which will give you 20.7, 2.4. Just an example, the patient who has a moderate risk will be categorized as high risk. So FRAX, use it always with correction. There are other settings where you will need to do FRAX corrections, but we will not discuss that here. But always if the patient is on higher dose of FRAX, do a corrected FRAX. After FRAX, the next step is risk stratification or categorization. For adults more than 40 years, there are 4 categories: low risk, moderate risk, high risk. And it's based on previous fracture history, the T-score, FRAX, and the glucocorticoid dose. Basically, if you don't have a fracture, if your T-score is less than, if your T-score is more than -1, and if the FRAX is less than 10%, 1%, and the glucocorticoid dose is less than 7.5, it's low risk. If the T-score is between -1 and -2.4, and FRAX is 20% to 3%, 1% to 3%, that is moderate risk. High risk is if the T-score is between -2.5 and -3.5, or if the FRAX for major osteoporotic is 20% and between 20% and 30%, or if the hip fracture risk is between 3% and 4.5%, you categorize as high risk. Anybody with a fracture, regardless of what their T-score and FRAX is very high risk. If their T-score is less than -3.5, it's very high risk. If their major osteoporotic fracture risk is 30% and more, or the hip fracture risk is more than 4.5%, or if their cumulative dose of steroid is very high, then they are at very high risk. Similarly, for patients who are less than 40, you have low risk, moderate risk, and very high risk group. There is no high risk group. Low risk is defined more or less the same way, but instead of the T-score, for patients who are less than 40, we depend on Z-score. So again, very high risk is any patient who's had a fracture, or if the Z-score is less than -3.5, or if the cumulative dose of steroid is very high. So identify the risk factors, do a DEXA, do a spinal imaging, and do risk stratification. Next is how to manage. In all these patients, regardless of what category they fall into, make sure they have adequate calcium and vitamin D. Calcium is between 1,000 and 1,200 milligram per day, either through diet or through supplementation. and aim for a vitamin D level between 30 and 50. Usually a dose between 600 and 800 should be okay for most patients. So the initial pharmacological treatment, apart from calcium and vitamin D, if the patient belongs to low risk, that's if the T-score is more than -1 and the hip fracture and the frax is less than 10% and 1%, that's basically the low risk. The strong recommendation is not to treat the patient. Moderate risk group, there is a conditional recommendation for treatment. It basically depend on ongoing risk factors, and it depends on the dose and the potential duration of steroid treatment. So moderate risk, there is a conditional recommendation of treatment, conditional recommendation for treatment. And if you plan to treat the patient, you could use oral bisphosphonate, IV bisphosphonate, denosumab, PTH, abaloparatide, or teriparatide. The next group is important, high risk and very high risk. There is strong recommendation for treatment. These patients needs to be treated unless contraindicated. If you choose to treat the patient, there is a preference to denosumab for high risk group, and there is a preference for PTH, teriparatide or abaloparatide in very high risk group. But basically you can use any of the treatment options available. Usually parenteral treatment is preferred over oral treatment, and anabolic agents are preferred over anti-resorptives in patients who are at very high risk, especially if they have a previous fracture. If you choose to treat a patient, usually you do fracture risk assessment at the end of the treatment unless the clinical risk factors change. SCR recommends doing a fracture risk assessment every 1 to 2 years. More so if the patient is not on treatment. If the patient is on steroids and not on treatment for glucocorticoid-induced osteoporosis, they need to be reassessed every 1 to 2 years with a bone density scan, DEXA scan, do a spinal imaging for occult vertebral fracture, and recalculate the frax. Now what happens if, it's very difficult to know if a patient is getting better on treatment or not. Failure is defined loosely so far, but ACR gives a definition of treatment failure as if you have a fracture after 12 months of treatment. Now these are patients who are at high risk of fracture. No treatment can bring down the risk of fracture to 0. So you'll expect some risk of fracture in all these patients. But if a patient has fracture, especially more than one fracture, and that too after 12 months, that's defined as treatment failure. And the other definition for treatment failure is significant loss of bone density after 1 to 2 years. So if you have treatment failure, you switch the treatment. Be careful with switching the treatment. Oral, if you are on anti-resorptive and if you put the patient on anabolic agent, there may not be as much response that you like you would expect if the patient has not been experiencing anti-resorptives before. But still, if the patient is on bisphosphonate, you can shift to denosumab, teriparatide, abaloparatide, or romosozumab. Raloxifene, again, you can switch to any of this. If the patient is on teriparatide, they can be switched to bisphosphonate or denosumab. If the patient is on denosumab, switching to teriparatide or abaloparatide may paradoxically decrease the bone density. So you could use either bisphosphonate or romosozumab. And if the patient is on romosozumab and treatment failure, you could go to bisphosphonate or denosumab. Now, if the patient has completed their course of steroid, they are not any more on steroids, and you think the fracture risk is is significantly better, and there is no other indication to continue treatment, you can discontinue the treatment. With bisphosphonate and raloxifene, you can just stop the treatment. With teriparatide, denosumab and romosozumab, always make sure you have something to follow up. So, there should be some treatment that is following up these treatments. With denosumab, there is a risk of rebound bone loss and increased fracture risk. So if you are stopping denosumab, make sure you give oral or IV bisphosphonate. 1 to 2 doses of zoledronic acid 6 months apart is the usual protocol that we follow. If the patient is on anabolic agent, and if you're stopping the treatment, make sure you give them, again, a bisphosphonate. If you put a patient on anabolic agent, end of 18 months, the usual treatment for abaloparatide is 18 months, teriparatide is 24 months, and romosozumab is for 12 months. End of treatment, if you don't give bisphosphonate, you literally lose all what you've gained within like 3 to 6 months. So you're basically treating the patient for no added gain. So always plan for sequential treatment when you plan to stop the treatment. Ideally, the sequence should be planned when you start the treatment. When you start the patient on denosumab, when you start the patient on anabolic, you should have a plan what you will be doing at the end of treatment. Now that's in brief about ACR guidelines. I've not gone to some of the special subgroups including pediatric population. I'll go to some of the difficulties in adapting ACR guidelines with our patients. The first thing is limited access to DEXA in India. We are all working in different kind of settings. Some of us have access to DEXA, some of us may not have easy access to DEXA. And even if we have access to DEXA, DEXA is hugely dependent upon the operator. The positioning should be correct, and the imaging sequences, like the imaging protocols should be correct. So make sure if you're using a DEXA, make sure you get it done from a reliable center, and make sure you have some form of communication with the operator who does the DEXA. There are a lot of criticisms about DEXA being used in Indian settings, especially with regards to the reference population. Basically, T-score is devised based on the normal bone density of an average North American male, which many people think is not a reliable thing to be defining osteoporosis in patients who are not in America, especially Asians and Africans. Even if you don't have DEXA, the good thing is you have FRAX. You can do FRAX without DEXA. But the problem with FRAX is the intervention threshold that we discussed, that 20%, 3%, which we take it as a holy grail, is not something which is defined for populations outside of US. So the whole 20%, 3% comes from cost efficacy analysis in US population, and how much of it is applicable to other group is something which we don't know. I'll come to this point in the next slide again. The next point is ensuring compliance and follow-up treatment with denosumab anabolic agents. I work in a setting where the clinician is responsible for following up the treatment. If I start a patient on denosumab, teriparatide or romosozumab, I'm responsible for bringing that patient to the clinic and starting parenteral bisphosphonate. But this may not be true for like many of you, like where the follow-up is patient-initiated. So, which is why it's important to see that compliance and follow-up is ensured before we start denosumab and anabolic agents. So the FRAX intervention, 3% and 20% for the US population. This may not be relevant for the other population. In UK, they use something which is called age-based threshold. This is based on the fracture risk of patients with previous fracture. There are studies which looks into age-based fracture thresholds in Indian patients, but none of them are validated so far. Most experts believe 22%, 10% or 3.5%, 14% would be a nice threshold for Indian patients. We don't have a consensus on this, but the take-home is patients who have a lower frax may need to be treated, and not just patients who have like 20% and 3%. I'm not sure about the time. I'll just discuss one case. I'll skip the other cases. The first case I have is a 71-year-old female. She has Graves' disease, and for the Graves' eye disease, she was on prednisolone, and this has been going on for some years now, and the dose is fluctuating between 3 to 5 milligram. The DEXA was done. The femoral neck DEXA is minus 2.0, and the lumbar spine DEXA is minus 4.1, that's severe osteoporosis. And you do a FRAX, which comes out to be 17.7% and 4.3%. Now, this FRAX does not need correction for glucocorticoid dose, but it needs correction for lumbar spine severe osteoporosis. In the FRAX, we enter minus 2.0, like we enter the femoral neck bone density, but this patient has a disproportionately low bone density at lumbar spine, and we'll have to do some correction for that. The correction is 10% for any one T-score difference. So the adjusted FRAX will turn out to be 21%. But regardless of what the FRAX is, the patient has severe osteoporosis. It's less than minus 3.5. So the patient belongs to very high risk group. Now the treatment options that we have available is alendronate, zoledronate, denosumab, teriparatide, abaloparatide, romosozumab, and no treatment. If you go through the guidelines, all of these treatment options are okay. We don't usually use oral treatment for very high risk group. So any of these treatment options are okay. This patient preferred not to do self-injection. They didn't want to do 6 monthly self-injection denosumab. They didn't want to have daily injections of teriparatide or abaloparatide. Romosozumab is monthly injection. So the patient opted for zoledronic acid, which is a reasonable option. We have good studies showing efficacy of zoledronic acid compared to oral bisphosphonate in glucocorticoid-induced osteoporosis. There is significant difference in the bone density if you start the patient on zoledronic acid single infusion instead of oral bisphosphonate. Now, when you start the patient on zoledronic acid, the most common concern is the risk of side effects. The risk of side effects, the most common things that we are concerned about is osteonecrosis of jaw and atypical fracture. But this is a slide which I use to educate patients if they want to know the actual incidence of risk. The risk of having a fracture when you have high fracs is much, much higher than the risk of having an osteonecrosis of jaw or an atypical fracture. The risk of having osteonecrosis of jaw is actually lower than the risk of having a death by murder in a Western society. So sometimes these kind of figures may help convince the patient to get on the treatment. So we started the patient on zoledronic acid. The question is how long? We go by the National Osteoporosis Guidelines. If the patient has ongoing risk factors, that is if the patient is more than 70, if the patient is likely to use steroids more than 3 years, or if the patient has a previous fracture, if they have all these risk factors, we counsel and start for 6 years. So it's yearly infusion for 6 years. If the patient doesn't have these risk factors, we counsel and start for 3 years, so 3 annual infusions. And at the end of 3 infusions, we reassess the fracture risk and treat them. I think I got the timer alarm already, so I'll just skip the other cases. The only additional thing I want to say that's come after the ACR guidelines is the use of romosozumab. There is a significant concern about cardiovascular risk of romosozumab. The two important trials that made romosozumab in the treatment of osteoporosis is the ARCH and the FRAME trial, which showed slightly increased risk of cardiovascular risk with romosozumab when compared to alendronic acid, but that risk was not in the other study. And most of the meta-analysis shows there is no increased cardiovascular risk with romosozumab. And there are studies to prove efficacy of romosozumab in glucocorticoid-induced osteoporosis. I believe that in the next update of the guidelines, romosozumab will come at least as effective as teriparatide or abaloparatide. So with that, I'll just conclude so I had a couple of cases more, but I'll just conclude my talk.
Thank you, Dr. Hafiz. Very good presentation. Due to lack of time, I think only 1 or 2 questions will be allowed.
So when you look at this DEXA score or the BMD, suppose if somebody has a mean BMD or T score of minus 2.8, but some of the values are outliers like 3.8 or 3.5, do you change your decision to treat or the choice of agent based on those values?
Yeah. So when you want to put, when you look at the BMD, it usually gives you femoral neck BMD, femoral, the head of femur. It gives you L1, L2, L3, and then it gives you an average of all of this. We usually go by the femoral neck and the average score. But if one of the spine BMD is disproportionately low, we still take that into consideration. A low spine BMD may actually be true, and the higher spine BMD in the other spines may be actually the effect of osteoarthritis or the spondylosis changes. So we look into this absolute individual spine as well.
So, a nice one, Hafiz. So, if there is a fracture, ongoing fracture, new onset fracture, and we are planning for anti-resorptives, should we be worried about the delayed healing of the fracture or something? So when can we give an zoledronate to a patient with an osteoporotic fracture?
Yeah. There was this concern about this theoretical risk of fracture healing getting affected by anti-resorptives. It's proven not to be a risk anymore. The ideal time for giving zoledronic acid is if the patient is admitted with fracture, give zoledronic acid then and there. It will go a long way in preventing refracturing, and it has mortality benefits. So the best time is to give the zoledronic acid when the patient is admitted.
Any cutoff for calcium you keep, or like?
Calcium should be normal. Calcium should be normal. Vitamin D should be replete. So when we start a patient on treatment, calcium, phosphate, vitamin D, and creatinine clearance is something which we look for. We don't give zoledronic acid for creatinine clearance less than 30. And as long as the calcium and vitamin D is replete, we are good to go. And sometimes we have a delay in getting the vitamin D results, in which case we just give a loading dose of vitamin D and give zoledronic acid. Patient going out of hospital without getting zoledronic acid and getting delayed to have the next zoledronic acid when they come up for the follow-up is not acceptable. So give zoledronic acid. Even if you don't have vitamin D, just give a loading dose of vitamin D. Calcium should be normal.
Your drug of choice for CKD with vertebral
difficult.
end of fracture.
Yeah, if the creatinine clearance is more than 30, you could go with any of the bisphosphonates. If the creatinine clearance is less than 30, it gets tricky. Denosumab is approved between a creatinine clearance of 15 to 30, but there is significant risk of hypocalcemia. So if you start a patient like creatinine clearance of 20, and if you want to start a patient on denosumab, it's okay. But there's a risk of hypocalcemia. And this hypocalcemia doesn't come like immediately after the injection. It comes like 10 days, 14 days after the injection. So the practice for us is to give the injection, and we do a mandatory 10-day calcium levels. And if the calcium levels are okay, we just educate about hypocalcemia symptoms. And we have not experienced dangerous hypocalcemia with these patients. Teriparatide, we don't have enough data. There are case series where they have used teriparatide for CKD stage 5, but I don't think that's something which we can recommend as a routine thing as of now.
So you will usually prefer denosumab over?
Less than 30, denosumab. Less than 20, we try to address all the other metabolic factors of renal disease, including calcium, parathyroid, and try not to intervene with these kind of drugs if possible.
One last question. Teriparatide won't work well for the neck of femur fracture, unlike the vertebral fracture. Yeah. So, but almost all the recommendations blanketly gives teriparatide also in very high risk patients. So, what do you use usually for NOF?
Yeah,
and
if there is a need for using anabolic agent, we don't have this preference between abaloparatide, teriparatide, or romosozumab as per any of these guidelines. That's true that neck of femur gain is not as much as with other anabolics for teriparatide, but it's still better than anti-resorptives. If given a choice, we would usually go for abaloparatide or romosozumab, which has shown consistently higher bone density gain than teriparatide. Abaloparatide has got a much higher anabolic effect than teriparatide. And romosozumab, if you see all the network analysis, romosozumab probably ranks 1 among the gain in bone density. And it's just a matter of time. Romosozumab and abaloparatide will become cheaper and be available more freely in this.
Once more, thank you for your excellent presentation. I know that there are a lot of questions. Lack of time, I cannot allow. So, thank you once more for this excellent talk.
Okay, we'll move on to the next session. So, for the next session, I invite Dr. Emil J. Techil, Consultant Rheumatologist, Lutz Hospital, Kochi, and Dr. Jijit Krishnan, Professor of Medicine, Government Medical College, Mancheri. Over to the chairpersons for the next.
Good afternoon all, good evening all. So I will directly go to the topic. The topic is, I believe, chronic inflammatory osteomyelitis, and I don't think anyone is more experienced than Dr. Suma Madam, who we all know, for addressing this topic. Over to you, Madam.
Thank you, Emil and Jijit. Thank you to the organizers for calling me here. So, CRMO or chronic recurrent multifocal osteomyelitis is actually a sterile inflammatory bone disease, which is seen much more in children than in adults, presents with mostly insidious bone pain and very little of systemic symptoms. This term came about in the 1970s. It was a Swiss radiologist who first recognized a pattern of patients from their radiology. Then a Swedish allergist who described them further and saw the connection between skin disease and bone disease. And then the first classification, the diagnostic criteria actually came from Bristol in 2016, the Bristol criteria. So we'll just look at a couple of case vignettes. This is a boy who, though his pain started at the age of 8 years, he presented to orthopedics for the first time at 11 years of age with left ankle swelling and pain. He was presumed to, he had osteomyelitis on imaging, and he was given ATT after biopsy was negative, etc., presumptively. And soon after that, he developed severe back pain and clavicular swelling and multiple other sites of pain. And the pain was localized to, he had thoracic vertebra, and he also developed a lower thoracic scoliosis. And then again they thought, after the investigations and the repeat biopsy was done, again it was thought to be tuberculosis, given the second course of ATT, again not responding, that's when we saw him. He had scalp psoriasis. You can see the kind of, this is not the day he came, this is after a couple of days. And you can see the deformity that is there, and he also had palmoplantar psoriasis. And this is his imaging. You can see the deformity in the spine, including the compression fracture that was there. You can see the lesions in his tibia, lower end of tibia around the ankle joint, and the clavicular lesion. So chronicity, recurrence, multifocality, osteomyelitis with skin inflammation. And this boy responded beautifully to bisphosphonate therapy. He was also put on methotrexate because of the psoriasis, and subsequent MRI showed complete clearing, and he straightened up. So this is another boy who presented to our maxillofacial surgeons with about 8 months history of a very painful right mandibular swelling. And it was so bad that he could hardly open his mouth, and he was drinking fluids by straw. And so the MRI showed again a large osteomyelitic lesion in the right side of his jaw corresponding to the lesion. Again, he had biopsies, he had numerous courses of antibiotics, he was not getting better. And this is a mandibular CRMO. We did a full whole body MRI, didn't find any other lesions, and again started him on NSAIDs with bisphosphonate. And after the first 3 doses of pamidronate itself, you can see how much he's able to open his mouth. And after completing the course of therapy, his lesions healed, and the MRI is also showed complete resolution of the lesion. So this is a CNO, unifocal disease of the mandible. This is a 12-year-old boy who presented just a few months back with pain in his chest and upper back. He was having difficulty in getting up after lying down. And he was actually presenting like as though he had an evolving myopathy of just the pectoral girdle. Though there was a history of nocturnal awakening at onset, which is suggestive of bone pain. And the neurologists were working him up, and they found nothing from his blood test. So he was sent off. You can see the hollowness of his anterior chest wall in this picture when he came. And so he went to have an MRI. His luck was that the pediatric radiologist was in the room when he was being scanned, and she observed these lesions in the spine. And she got curious, looked back at the clinical history, and extended it to a whole body MRI. And there were lesions in the lower femur, in the pelvis. And this is another CRMO story. He had lesions in the D3, 4, 5 vertebrae, in sacroiliac, right acetabulum, right pubis, etc. And this is CRMO again. And so we treated him with bisphosphonates, and within, for the first 3 doses of pamidronate itself, you can see that that hollowing is improving, and he was cycling and very active. So basically, there are many presentations like this. It's considered a rare disease. I'm no longer convinced that it is so. I think it is rarely thought about. And there is an incidence quoted between 0.4 and 1 per 100,000, but it's possibly more common than that. In Germany, they've actually done a 10-year continuous survey, and they found that the incidences of both CNO was comparable with the incidence of infectious osteomyelitis in their patients. So that really bears thinking about. And generally in school age going children, more common in females but more severe in males, and happens in all ethnicities. The pathophysiological mechanisms, if you're looking at, there's basically an imbalanced cytokine expression in these patients, where you have an overexpression of pro-inflammatory cytokines and less of the anti-inflammatory cytokines, which leads again to significant inflammasome activation, particularly the NLRP3 inflammasome, which activates NF-kappa B, and that activates the Rankel ligand and sets off an osteoclast differentiation. The increased osteoclast activation leads to these lytic lesions and the format of the CRMO that appears in the bones. We have monogenic causes of CRMO, and there are slowly an increasing numbers. So these are the 4 mutations that are put up there, and actually the monogenic causes of CRMO have helped us understand the pathogenesis of CRMO also a bit better. And the reason that we need to know the pathophysiological mechanisms is that they help us in knowing how to tackle them treatment-wise. Clinically, when do you suspect CRMO? Bone pain in a child who's otherwise looking well. That is the simplest way to put it. And I think it's really important clinically to differentiate bone pain from joint pain and from other kinds of pain. They could also have, the systemic features are usually less common. Arthritis of the contiguous joints is frequently seen, and they could also have skin inflammation, which could be acne like you see in Sappho. It could be palmoplantar pustulosis, which is more common in adults, or psoriasis, any of the spectrum of psoriasis. These lesions usually spare the neurocranium. There has been no single report so far about CRMO in the skull. Labs-wise, you'll find that these patients have a lot of bone pain, but their labs look quite frighteningly normal, actually. Most may have a little bit of leukocytosis, some increase in ESR-CRP, not very high. So because of that, the quest for biomarkers has been vast, and really there's been nothing that can be used in practical terms uniformly so far. Probably time will give us some more. And if you're looking at the imaging, X-rays, they're not always going to show you the lesions. If you see the osteolytic lesions on X-rays, it's useful, but quite often you get, when there is sclerosis or when there's fractures or when there's been a significant chronicity, you may see changes, but fairly early lesions, it'll be quite normal. Bone scans are not at all recommended in the pediatric age group. One thing, they bring up a lot of false positives because of the effects of growth, and they are also high radiation. CT scans again are not what is the recommended imaging. MRI is the recommended imaging, particularly whole body MRI scans, which can actually show up even the silent lesions where the patient doesn't have symptoms. And that can often, when a patient comes to you maybe with a pelvic pain and you see one lesion, they're doing a whole body MRI scan, and you see other lesions, you don't need to do a biopsy for this patient. You can spare them the need for a biopsy. CRMO is not uncommon in adults, but it is far less common than we see it in children. And in the West, it's reported that children have far more clavicular lesions compared to adults, and skin-associated disease, particularly palmoplantar pustulosis, is much more common in adults as compared to children. I don't see, I mean, in our series, I don't think we've seen that much clavicular lesions. We've seen more of other bones. We have seen clavicular, but not that much. And all children don't need to have bone biopsies. The role of a bone biopsy here is basically to exclude other diagnoses. So if you're not sure of what's going on, you don't think the picture is pakka CRMO or it's a single lesion, then I think go for a biopsy. Okay, and you don't need a biopsy for every patient, especially when the typical features are there. And believe me, we've had patients with non-caseating granulomas in CRMO. So the presence of non-caseating granuloma on your biopsy alone should not be an indication to give ATT to this patient if all the other features are like CRMO. So the biopsy pictures can be quite varied, can vary from absolutely nothing to varying levels of inflammation. It also depends on the timing of the biopsy. We have two sets of clinical criteria which are used for diagnostic purposes. And this patients should satisfy either one of these to make a diagnosis. The criteria are, they've been set in such a way that even for unifocal cases, you will know, you can look at it and get support for your diagnosis. They look at, it's a combination of clinical and radiological pictures, and the radiological pictures invariably MRI. And the other thing is the typical CRMO does not have very high elevated inflammatory markers. If you have very high elevated inflammatory markers, you have just unifocal disease, particularly if it is not the clavicle, it is recommended, it's better to do a biopsy. And if your MRI appearances are not the typical metaphyseal kind of lesions, it is also recommended that you consider doing a biopsy. And the differential diagnosis is very vast, hence this very busy slide. So infections, malignancy, various congenital conditions, metabolic conditions, many mimics are there. So it's important, again, history examination is the key most of the time. Show you a couple of mimics. So this was a young teenage girl we came across a few months ago. She had, in 2022, she had a right tibial diaphyseal lesion that you can see in here. And, oh gosh, what happened? Okay, so you can see it on the first picture. It's not actually, here. You can see it on the first picture, and that was biopsied and found to be not significant. Then she comes back this year with severe bone pain of the left lower limb, yeah, of the left lower limb, and she has identical mirror image lesion in the left tibia now. The right tibia is completely gone. And you can see this here. This is a close-up. And these are diaphyseal lesions. Her symptoms did look like CRMO, but this is not a typical CRMO lesion. It requires a biopsy. A biopsy was done. At the same time, when you have recurrent diaphyseal lengthy lesions like this, you have to also think about a rare metabolic condition, a hyperphosphatemic familial tumoral calcinosis. And so we investigated for that too, and that was also negative. We treated this patient subsequently as a CRMO with great success, but we had to go through the exercise of making sure it was not anything else first. Another 18-month-old child who came with recurrent episodes of high-grade fever and bone pain. And she also had neutrophilic lymphocytosis and quite severe anemia. She received a transfusion in that process. And again, very high ESR and CRP. No skin lesions. So suspecting CRMO, we called her, we did a bone marrow and we did a whole body MRI scan. You can see that many long bone lesions are seen symmetrically on both sides. And it's actually this extent of inflammation that is causing this anemia. It's an anemia of chronic inflammation that she has. And young child, this kind of picture, monogenic cause is highly likely. So straight away we did a whole exome sequencing and confirmed a diagnosis of Majeed syndrome. Though Majeed syndrome is a triad of these three, of CRMO with dyserythropoietic anemia and neutrophilic dermatosis, the 4 Majeed syndrome I have, none of them have the other features. They all have only early onset CRMO. And this is another very interesting patient, a 15-year-old girl who had initially diagnosed as left ankle osteomyelitis. First they thought was infective. She was given antibiotics, she didn't respond. Then they thought it could be CRMO, so they gave her zoldronic acid. She did have some response, but she came back within 3 months with severe pain. And at this point, an MRI was done, and you can see here, each of these shows there are multiple lesions to be seen, not all metaphyseal, several diaphyseal lesions as well. So that's when the patient came to us. We did a whole body PET for her, and you can see that there are not just bony lesions in multiple sites, there are also soft tissue lesions here in this patient. So we went ahead and did a biopsy of the soft tissue lesion, confirmed it as erythema chester disease. So that's why it's important to think of mimics when the clinical story or the imaging pictures are not pakka. You have to think about mimics, and we have to think about biopsies, we have to think about other options. In a nutshell, if I saw a child with bone pain suggestive of CRMO, I would look to see if there were other skin manifestations, if there are other systemic inflammatory diseases this child has, so skin inflammation, inflammatory bowel disease. I would also look to see if the child had pathological fractures. If the initial imaging pictures, because most probably the patients come to me with already some imaging, are suggestive of CRMO, I would go for a whole body MRI to detect subclinical lesions as well and see the total number of lesions we have. In this scenario, you can make a diagnosis of CRMO, you don't need a biopsy. However, if your imaging features or your clinical feature is not exactly suggestive, or you have red flag signs, like so, then it's better you go for a biopsy and and then treat the patient. If your patient presents very, very early with all these features, go very early for genetic testing. And this is what you need to know how to manage the patient. This is just a single slide to show this boy came with severe pelvic pain and back pain, and you can see that there is a lesion here, but it's not very well seen on the X-ray, whereas the MRI shows the big lesion that is there in the pelvis. So that's why X-rays are not very good in children to pick up these lesions. The goals of treatment is to not just control the symptoms for the child, but to avoid complications of prolonged bone inflammation, and to treat them with without too many side effects, and also think of the systemic, if the child has other inflammatory bowel disease or psoriasis, etc., include that too in your treatment protocol. Treatment-wise, we don't have FDA-approved meds. We don't have RCTs. It is expert opinion, case series, and really not very high-level evidence that is there. We just have consensus opinion to manage most of the time. The first-line therapy is NSAIDs. Very rarely we would use corticosteroids first line to control the acute symptoms. And this is usually the drugs that we use. So NSAIDs help by the antiprostaglandin really reducing the inflammation, and mild cases of CRMO, NSAIDs may be the only thing you need. You need long courses. 2 weeks, 3 weeks won't do. You need to go for a few months with NSAIDs for these patients. But many patients do not respond also to NSAIDs. Bisphosphonates are very, very effective. They help to actually reduce that osteoclast activation and heal the lytic lesions. Then you have anti-cytokine drugs, which work being anti-cytokine drugs. And with DMARDs like methotrexate and sulfasalazine, it's more towards treating associated arthritis, treating associated psoriasis and things like that. And sometimes as a third line when the initial bisphosphonates, etc., have still left some residual disease for you. With bisphosphonates, we have again case series. This was the first case series that came out, and it showed good response in the patients who had spinal lesions. This is a much bigger series. This is multi-center UK series report on CRMO, where they showed nearly 70% resolution of children with spinal lesions with bisphosphonates. And we have the CARA consensus treatment plans where all patients initially are started on NSAIDs, but patients who have spinal lesions and structural bone lesions, so bone lesions which show deformity, enlargement, collapses, or cortical breach, then these patients need additional treatments. You can either go for bisphosphonates, you can go for anti-TNF, or you can go for and very where nothing else available, you can think about using methotrexate or sulfasalazine, though the evidence is really, really poor for that line of drugs at this stage. With bisphosphonates, pamidronate and zoledronic acid are used. I use more pamidronate, though I think the world over there is a trend shifting more towards zoledronic acid now. And the important thing is whatever you use, you do have to repeat imaging to see the outcome of your treatment. In the West, they advise repeat imaging every 6 months. I tend to do it once a year because it's expensive for patients. And it's also been found out that if you have involvement of femur, pelvis, clavicle at baseline, high ESR at baseline, and significant multifocal disease, the long-term outcomes are going to be more complicated. And it's better that you don't treat these patients just with NSAIDs, give them more treatments up front to prevent the outcome, to get better outcomes in the long term. So far, we have 101 patients, and male-female ratio is almost equal. Median age of presentation is around 10.7 with an age range between 4.5 and 18.2. Median symptom duration is about 8 months. We have about 1/3 of our patients have vertebral involvement, and about 17% have mandibular involvement, of whom about 12 patients are only mandibular involvement, unifocal only mandibular involvement. Then we have about 78% of our patients are multifocal and 22% are unifocal, and about 61% have lesion severity at baseline based on the previous characteristics I showed you. But 42% have had biopsies. Not that I requested biopsy for them, but several have come to me with biopsies, and for some patients we have additionally done biopsies. And not very high ESR and CRP in the majority. About 1/3 of them have comorbidities, the commonest of which is psoriasis, and 2 patients with SAPHO, and 2 patients out of the 40 screened are positive for HLA-B27. Apart from this 104, we have 4 patients with monogenic CRMO, that is Majid syndrome. And every patient has received NSAIDs. Only 2 patients required steroids for the initial induction of treatment. All the others have had initial treatment with NSAIDs, and then given, the majority of our patients have had pamidronate, about 2/3 have had pamidronate, and very few have had biologics in our series. And the JAK inhibition has been mostly for patients who have evolved towards spondyloarthropathy. We do see that evolution happen. And most of our patients, be it vertebral or mandibular, they have responded very well to bisphosphonate therapy, and very few have needed crossover of treatment to other modalities. About 2/3 have undergone a repeat whole body MRI, and more than 2/3 of those have shown complete resolution, with some patients showing persistent or new lesions, and then you add in other drugs when that scenario happens. So I'll just stop now. So children with insidious bone pain who are otherwise systemically well, please think about CNO and CRMO. It's a lot more common than we think it is. Whole body MRI is extremely important in the diagnostic and follow-up evaluation. At this point, I will also say having a pediatric radiologist or a radiologist who's very experienced with interpreting these films is extremely important in getting the diagnosis here. Every patient does not require a biopsy, and they are better managed in centers which have experience with managing them. Do not forget mimics, and the goal to create a registry is very much there. Let's see if we can achieve it. Thanks to my colleagues, my 2 PGs who put the data together for me, orthopedic surgeons, the pediatric radiologist who's hand in glove with me for all these patients, and of course my department. Thank you.
Thank you, ma'am. Nice cases, wonderful presentation. Topic is open for discussion. Just 2 questions, please.
How long will give treatment? Palmindronate, how long should we give?
What is recommended is 12 doses. So you can either go, I give the option to the patients, you want to come monthly, take 1 dose and go on OPD basis, or you want to have 3 monthly, 3 doses. It's up to you. And when you give 3 simultaneous doses, it's better to have the patient as an inpatient because the side effects are much more pronounced in those patients. Zoledronic acid would be a better alternative. It's a little more expensive. And actually, my endocrine colleagues are very, they do not like zoledronic acid for some reason, which is one reason why I have been more reluctant to use it. I've probably used it in about 4 patients in my series.
Should we be worried about their growth, children's bone growth?
No, that is something with osteogenesis imperfecta, we have very long-term data on growth in children on bisphosphonates. There's no concern.
Then why are we rushing it at 1 year? Like, what will happen if the patient relapses, or wait for the relapse and then restart, or should we
change
add
the treatment. We change the treatment. So we repeat a whole body MRI, and if they have, say, incomplete clearance of lesions, new lesions, then I would actually either change the treatment to, and if they can afford it, anti-TNF. Most of the time, that's the time I add in methotrexate for these patients, and they tend to settle down.
After 1 year, we'll add methotrexate.
And if it's just a relatively simple lesion, new lesion that is there, I would just give them a course of NSAIDs, a 3-month course or something. That should also do for some of them.
Thank you, ma'am.
Thank you.
Next talk is by Dr. Anjana Vaidyer. She is a consultant rheumatologist at PRS Hospital, Thiruvananthapuram. As you all know, myositis can be very difficult sometimes to treat. So Dr. Anjana will be talking to us on this topic.
Good evening, everyone. Thank you, ML sir and Jijit sir. Thank you, Corco team, for giving me this opportunity. So, coming to refractory myositis. When do you call myositis as refractory? It is when the disease worsens or relapses after treatment with a usual high-dose glucocorticoids plus at least one immunosuppressant, which is usually methotrexate, azathioprine, or mycophenolate at a maximum dose for at least 3 months. The disease can worsen or relapse, or sometimes they may develop side effects, adverse effects to this treatment. Then we call it as refractory myositis. This is the definition which has been employed in most of the trials on refractory myositis. So, you have a patient with idiopathic inflammatory myositis who presents with typical proximal muscle weakness, typical skin changes, or a case of polymyositis, and you do a biopsy, muscle biopsy shows inflammation, and then you start on oral glucocorticoids plus either methotrexate or azathioprine or a mycophenolate mofetil. Either you continue the treatment at 3 to 6 months, you realize that patient is not optimally responding to treatment. So what to do? Do you directly increase the immunosuppressants, or you do further evaluation? So first, what you have to decide is whether the remaining symptoms that is happening in the patient, whether it is the muscle weakness or the skin symptoms or the respiratory symptoms, is it because of the disease activity per se, that is because of the inflammation, or is because of the damage which has occurred over the time with the disease as well as with the treatment. Then second thing you have to consider is the diagnosis of myositis correct? This is important when it comes to patients when you diagnose as polymyositis. When the patient has proximal muscle weakness and you don't have any other cutaneous features of dermatomyositis, and if the MSAs, the myositis-specific antibodies and the myositis-associated antibodies are negative, but maybe biopsy was showing inflammation, so you started on the immunosuppressants, but patient is not responding. At this point, you need to think of myositis mimics. You need to think whether is it myositis or something else. Then based on this, you need to develop a strategy to change treatment. So how do you decide whether the disease is because of inflammatory active disease or damage? Clinically, check the MMT, the muscle weakness MMT score, check the skin scores, CPK levels, LDH levels, aldolase levels, but these levels may normalize even with active disease if the patient is on glucocorticoids. Best thing is to do an MRI. Repeat an MRI. If it has already been done, in any way repeat an MRI. The stir and fat suppressed T2 images may indicate, with muscle edema, will indicate ongoing inflammation, but this can also be seen in some dystrophies. Even if you have done a muscle biopsy in the beginning and it has shown endomysial inflammation, if the patient is not responding, it is better to repeat a muscle biopsy. But at this time, it is better to do an immunohistochemistry, EM, and in consultation with a neurologist, it will be better to do a genetic test to look for other genetic myopathies, dystrophies, mitochondrial myopathies, etc. When it comes to respiratory symptoms, the patient is having a persistent symptom or worsening respiratory symptoms, do a PFT. If the PFT is showing worsening, go for HRCT chest and assess the change in whether the symptoms are whether the findings have increased. Dysphagia, if the persistent dysphagia is a usual problem, especially in anti-SRP and anti-NXP2 patients. Assess the motility, do a swallowing test, assess the motility of the esophageal and pharyngeal muscles by various techniques like video, scleroscopy, endoscopic evaluation of swallowing, manometry, or a real-time MRI, which I am not sure is available here, to assess the pharyngeal muscles. So this is a nutshell about how to approach patient with an refractory IIM with persistent muscle weakness, determine if the active inflammation, it is because of inflammation or damage. If there is no features of inflammation, taper steroid and continue physical and decide on optimizing the physical therapy. But if there is a evidence of inflammation, either in MRI or the muscle biopsy, check for skin rash, dermatomyositis skin rash. If it is persistent, then it will be better to again do a repeat cancer screening. If the cancer screening comes positive, it's up to oncologist. If there is no skin rash, and that is when you have to consider, it is better to repeat the myositis specific antibodies or the myositis associated antibodies. If it is positive, then go on with the decide on increasing the immunosuppression. If it is negative, that is when you have to consider the myositis mimics. Even in the presence of muscle biopsy showing inflammation, that is the point. Even in the presence of muscle biopsy showing endomysial inflammation, it still can be a genetic myopathies. So inherited myopathies, especially dysferlinopathy, calpainopathy, facioscapulohumeral dystrophy, can be misdiagnosed as autoimmune myopathy even when they have inflammatory muscle biopsies. Inclusion myositis in the early stages can be diagnosed as polymyositis when rim vacuoles are absent on muscle biopsy. So this is a distinguishing features between myositis and genetic myopathy in nutshell. Younger onset in childhood, except for when there is cutaneous features, when there's a positive family history, when there's asymmetrical distribution of weakness, think about genetic myopathy. Polymyositis before pointing to the diagnosis of polymyositis, always better to look for a genetic test. So if you have weakness without signs of inflammation, then it is a persistent damage. The weakness is likely due to the muscle atrophy or replacement of muscle with fat and connective tissue as a consequence of previous inflammation. It can also be a glucocorticoid-induced myopathy. If there is muscle pain without weakness, think about fibromyalgia and chronic widespread pain. In all these cases, optimizing the physical therapy will help in improving the outcome to some extent. Then, occasional patients may have a transient elevation of serum CK levels after exercise, but this doesn't you shouldn't increase immunosuppression or stop the physical exercise even if there is an increase in CK observed. So what are the treatment options available for refractory myositis patients whom we had decided that there is active inflammation and for whom all myositis mimics have been ruled out? So classically, the first line glucocorticoids of methotrexate, azathioprine, MMF. Second line, either you can use a combination of methotrexate, azathioprine, mycophenolate mofetil in case of associated with ILD. You can add cyclosporin, tacrolimus. Third line therapy, there are several other options. So what are the evidence? Next, I will be going through the evidence of all these drugs in refractory myositis. First is intravenous immunoglobulin. IVIG has been used is one of the first drugs to be used in the treatment of myositis from the 1950s. The first trial was in 1993 when they conducted a study in 15 patients. 8 patients received IVIG, 2 mg per kg every 4 weeks for 3 months. And the other group, 7 patients received placebo. As you can see here, the MRC score the MRC score and the neuromuscular symptoms improved at 3 months in the IVIG group than the placebo group. This is the first trial of IVIG in refractory dermatitis who had already received methotrexate, azathioprine and glucocorticoids. Then there is a recent study, 2002 study, where almost 90 patients were studied, the refractory myositis patients who had already received other immunosuppressants were entered into the study, and the patients received IVIG monthly for 16 weeks. At 16 weeks, you can see that the ACR-EULAR total improvement score was much better in the IVIG group than the placebo group. This data couldn't be compared. So, but problem with IVIG is high risk of infusion reactions and thromboembolism, and top patient tolerability taking every month is also a problem. In these patients, subcutaneous immunoglobulin can be given. There is studies on efficacy and long-term benefit. Next is anti-CD20. Rituximab. B cells have a pretty good role in the pathogenesis of myositis because of the presence of the antibodies as well as the presence of B cell inflammatory cells in the biopsies. So many case reports and case series has demonstrated beneficial effects in treating severe refractory dermatomyositis, but the RHEUM trial, which was the biggest trial of rituximab in dermatomyositis and polymyositis, they couldn't achieve their primary outcome. In RHEUM trial, almost 200 patients were entered. Half the patients received rituximab early, half the patients received rituximab at week 8. The primary endpoint was mean time to reach the definition of improvement. There was no much difference in this group, but however, it should be noted that 83% of the patients achieved. Though there was no difference between the group, between early and late, 83% of patients achieved improvement. So that shows that in refractory myositis, rituximab is good enough. And a post-hoc analysis showed that presence of the antibodies like anti-Jo1, anti-Me2, Tiffin gamma, etc., strongly predicted clinical improvement. That is, rituximab shows good improvement in patients who are autoantibody positive. And it also showed that there is a decrease in the titers of these antibodies post-treatment. This is systematic analysis which showed rituximab was effective in 62% of patients with refractory IAMs and 68% of patients with dermatomyositis and polymyositis. They found that MSA and MAA had better response. The JDM subset had better response, and lower disease damage predicts better outcome. Next is the JAK-STAT inhibitors. After B cells, the one implicated in the pathogenesis is the type 1 interferon, and hence the trial of JAK inhibitors in dermatomyositis. Overall, this is a systematic review of various studies of using all the JAK inhibitor like tofacitinib, baricitinib and ruxolitinib. It showed that patients with adult dermatomyositis, almost in ILD patients, there was a 94% patients improved with JAK inhibitors, and it was especially good for cutaneous refractory skin disease and calcinosis. And there is also much reduction in the interferon signature in these patients. So this is the first trial on open label clinical trial on tofacitinib, the STIR trial, where 10 patients were given tofacitinib 5 mg, 11 mg extended release. It is shown that 70% the total improvement score was much better in these patients, and the total 75% of 4 patients, 70% of patients showed an improvement from moderate to severe skin disease to mild disease activity. This is another Chinese study which showed the efficacy of tofacitinib in CADAM, anti-MDA5 positive patients, where 18 patients were compared with an historical control. It should be noted that all these patients were patients with a anti-CADAM patients, anti-MDA positive with ILD, with an FVC of at least more than 50%. No RP-ALD patients were there. It should be noted, not a single patient in the tofacitinib group succumbed to the condition during this period, while the historical control group exhibited distressing mortality rate of 22%. So based on this trial, some have been advocating that if the patient is anti-MD5 positive, you can start upfront tofacitinib to prevent progression to RP-ALD. So what about our generic tofacitinib? This is the Showman study, which is a retrospective study showing the effectiveness. Overall, complete or partial remission was achieved in 64% of patients at 3 months, 85 at 6 months, and 96 at 12 months. There's a reduction in also. It was also possible to reduce the steroids, and better outcome was seen in the cutaneous part. Baricitinib and ruxolitinib has been shown to show improvement in skin scores. Upadacitinib has also been shown to show improvement in skin scores. CDASI scores pre-upadacitinib 12, which has changed to 4 at 3 months. Next is the ACTH, which is a repository corticotropin injection, which is FDA approved since 1952, and its efficacy has been proved in a trial. Then this is a very recent trial showing the efficacy of abatacept in refractory idiopathic inflammatory myopathy. Here it should be noted that there was no difference in treatment were observed among patients with dermatomyositis receiving abatacept and placebo, but among patients with polymyositis or immune-mediated necrotizing myopathy, response rates were higher in the abatacept group than in the placebo group. So abatacept is recommended by the BSR guidelines in refractory myositis. So then there has also been studies of TNF inhibitors like infliximab and adalimumab in refractory myositis, but etanercept is not preferred because it is shown to increase the skin condition. In adults, I didn't find any recommendation for using TNF-I, but one recommendation is present in JDM for using infliximab or adalimumab in refractory myositis as a 3rd line or the 4th line. So these are the various drugs we have. So how to decide on the treatment? So before we have to at least wait for 3 months to measure objective improvement of muscle performance. So the treatment, you first try switching the whatever immunosuppressants we are using. If you are using methotrexate, you can shift to MMF, or you can shift to azathioprine or cyclosporin or tacrolimus. If it has still not improved, Then, depending on the MSA and in presence of MSA, you decide. If there is skin rash, consider IVIG or rituximab. If there is a myositis specific, depending on the myositis specific antibodies also, you can decide. Anti-synthetase antibodies, rituximab is better. Anti-SRP antibodies, rituximab it is better. Anti-HMG reductase antibody, you can consider IVIG. IVIG can be used first line in anti-HMG CoA receptor antibody positive IMNM. If all these fails, consider switching to JAK inhibitors. In dysphagia, persistent dysphagia, you can try IVIG. Persistent skin rash, you can try IVIG. Anti-HMG CoA receptors, try IVIG. All other MSA positivity, try rituximab. Refractory ILD with persistent inflammation, any myositis patient with ILD, initially itself you should give aggressive immunosuppression, preferably with IV migdal pulse. You can consider mycophenolate profetyl or cyclophosphamide also. Refractory ILD, consider adding rituximab. Rapidly progressive ILD, current recommendation is to initially start on IV migdal pulse plus cyclophosphamide plus either tacrolimus or cyclosporin. If it doesn't respond, consider adding rituximab. If doesn't respond, consider adding IVIG or plasmapheresis, etc. So this is a recommendation in patients with refractory ILD. Moderate ILD, you can consider glucocorticoids plus MMF or calcineurin inhibitor. If it is not improving, add rituximab or cyclophosphamide. Severe ILD, upfront cyclophosphamide, or you can use a combination of MMF plus cyclosporin. If it is not improving, again combine rituximab or cyclophosphamide. If it is still not improving, you will have to think about lung transplantation. In between, you can consider Plex also. Refractory skin rash, there are several drugs. Hydroxychloroquine can be used. Severe case, IVIG can be given. Tofacitinib has been shown to be efficacious. Apremilast has also been shown to be to some extent efficacious in refractory cutaneous dermatomyositis. Then lenabecestat is a cannabinoid receptor which has also been found to be good in some studies. You can use dapsone, naltrexone, leflunomide has also been shown to be efficacious in some studies. Previously, ustekinumab was proposed to be effective on mechanics hand, but a later study showed that there is not much difference in outcome. Any patient with dysphagia, proton pump inhibitors are must. PEG should be, percutaneous gasotomy should be considered. IVIG can be considered in this patient with refractory dysphagia. Along with that, physical therapy and swallowing exercise is a must. So, this is the latest BSR recommendation here for refractory disease, IVIG or cyclophosphamide to be considered for severe refractory myositis, rituximab to be considered if showing positive myositis antibodies. Here it is, abatacept has been recommended for refractory myositis. So, with the discovery of the MSI and MIA, you can tailor the treatment option. In antibody, if there is autoantibody negative, always revisit the diagnosis. Thank you.
Thank you, Anjana, for the presentation. Request open for discussion. Any questions or queries?
How often should you go for this CPK evaluation on a regular basis? Do you follow up with that? Muscle-specific antibodies, muscle?
How often I haven't checked, but regularly we check. Anyway, at 3 months and 6 months, you definitely need
Can
to
we say that the disease is under control when the CPK is normal?
No. Glucagon treatment itself will reduces CPK levels with features of persistent inflammation. You cannot, a single test won't, a combination of tests is needed to assess the disease activity rather than a single test, along with clinical analysis.
And what about rapidly progressing ILD, role of tacrolimus?
Tacrolimus is to be given first line. A high dose glucocorticoid pulsing plus tacrolimus plus cyclophosphamide is current latest recommendation.
Any questions? I think we'll stop the session and we'll close the session. Thank you.
Thank you, chairs, and thank you, speakers. And we'll move on to the last session